So, minimally invasive AVR, it's very safe, it's very reliable, it's very reproducible. So we don't want, again, going back to the 4 inviolate principles, we don't want to be introducing things into isolated aortic valve replacement that's going to endanger the patient, make things worse, increase complication rates. Here at our center, we have, knock on a big block of wood, but we haven't had a death in an isolated AVR since about 2012. It's like close to 300 patients. Those patients have been carefully selected. We have a active TAVR program, so I think that helps that, but we certainly want to maintain that. And we've been doing minimally invasive AVR all along that time concurrently with that. So it is safe, it's reliable, and reproducible. So, Jason, this is not working here on the clicker. Not sure why, sorry. I have to call Dr. Youssef. I told him everything I knew and then I forgot. Oh, okay, very good. Take it for a minute to pop up. Okay. Yep, okay, good. Okay, so, getting right down to the fundamentals, then there are 2 incision types, all right? There are upper mini sternotomy, and there's a right intercostal approach. And before I forget it, I'll refer you to, some of this comes out of an article that we published in January of 2014 in the JTCVS journal under expert review. And there's a lot of very good diagrams in there. It gets very much into detail and the granular portions of how to do mini AVR. These come with their own sets of circumstances, and they are applied in different settings. Again, I mention this again because this is very important. I feel very strongly about this. Inviolate principles of accomplishing safe cardiac surgery. So again, with AVR, we're going to establish and maintain adequate perfusion. We're going to have optimal myocardial preservation, we're going to have uncompromised exposure, and we're going to have optimal procedure choice for the patient. So let's take upper mini sternotomy first. What are the advantages of doing an upper mini sternotomy? Well, you have more options. You can do an AVR, a root enlargement, aortic root enlargement, a root replacement, an ascending aortic replacement. All of these things have been done and reported. You have to be careful and selectively once you get away from AVR, but root replacements as well as ascending aortic replacements have been done through this incision. I personally have not done any to many of those, sort of 1 or 2. I worry a little bit. I'd be cautious about the root replacement because once you do that left coronary button on a root replacement through that small incision, trying to see that to put a repair stitch in that can be quite difficult. But there are very good surgeons that have reported that. We do here direct arterial cannulation. So the advantage of the mini upper sternotomy is that you're doing antegrade perfusion. All right, so that's why we just do a non-contrast CT for an AVR. We're going to cannulate just like we normally would, and I'll show you that here in just a minute, or in a few minutes with a short video. Any valve type is implantable, tissue or mechanical. And as I've mentioned before, it's very good for obese patients. The disadvantages of a mini upper sternotomy: it's more invasive, it's a greater wound burden than a right anterior thoracotomy, it's less than a full sternotomy. There's more concern for sternal healing because you are violating the sternum. And the recovery advantages over the full sternotomy are less apparent. So the patients in the hospital will look about the same as a sternotomy patient to everybody, the staff and everybody. But once the patient goes home, they are usually a week or 2 ahead of a patient who has had a full sternotomy. Right intercostal approach, mini AVR. So the advantages is that you do not disrupt the sternum. It's done through a second or third, usually a third intercostal space. You divide the cartilage, and if the exposure is adequate, it's quite good, but obviously you're not dividing the sternum and there's no sternal disruption. Therefore, that is a key element in how these patients do. Much quicker recovery than a mini upper sternotomy. I did about 30 of these when I first started doing surgery, mini invasive surgery back in 2004, 2005, and it's amazing how well these patients look. They're a bit more challenging in terms of the exposure and the reproducibility of the exposure, and we'll get into that in a little bit. The disadvantages is that you're going to be doing retrograde arterial perfusion. Now, I knew of one surgeon that cannulates through that incision, but once you start doing that, you're starting to compromise the exposure element. You get a lot of stuff coming out of there, and Dr. Stout referred to that before. The more stuff we can get out of the incision, the better access that you have, and the less chance for dislodging anything. The exposure may be less predictable. I was referring to this before. It's this slide, that statement is a little bit dated. There's a fellow by the name of Mate Glauber who was in a small city in Italy, but now is in Milan, who have done hundreds of these through right anterior thoracotomy. So his group in, I think it's 2011, it's published in the Annals of Thoracic Surgery, looked at the CT scan to look at the predictive value of a CT scan to show whether or not you could predict whether that patient was going to have adequate exposure. And in fact, what he found, which is what you would think, is that the aorta is uncurled and lying in a 45-degree angle, which we see quite often. If you do a right anterior thoracotomy approach, you're looking as a surgeon head here. If I'm the patient surgeon head here, looking in this way, you're looking right at the aortic valve. However, and then we have this in the paper that I referred to in JTCVS, if the aorta comes straight up, like we see from time to time, you are in deep trouble from over here, because from over here you're looking in and you're looking to the same plane of the annulus, and you can't begin to see the valve. The most commonly encountered difficulty with in my experience, with a right anterior thoracotomy approach is the suture replacement and the suture tying between the left coronary cusp and the right coronary, the left-right commissure. The reason for that is the stent post is sticking straight up, and you cannot many times see around that area. Now, what I have not done is use the core knot in that situation, because we now have routinely gone to core knot use for all of our AVRs, and for any suture placement for valve, we use core knots now. So that may take that off the table, and I haven't had the personal experience to try that yet. And this refers to the fact that the Hancock valve actually is facilitative of this, because you can take those three stents and sort of turn them in and put them down. Joe Lamellis does a great job. In fact, I learned from Joe back in 2004 with this approach. And you can actually see over that stent at the left-right sinus, at the left-right commissure. The Edwards post can be a little more challenging because it's sticking straight up and can be in your way. So just little tricks there to think about. So it's routine pre-op for AVR. Obviously, you're going to do a cath, make sure they don't have coronary disease. Again, it's good for obese patients. Chest CT, we feel, again, is mandatory. Dr. Youssef has done a beautiful job presenting all this. You want to look at the ascending aortic size. If it's a bicuspid valve, do they have associated ascending aortic dilatation or enlargement? Are you going to have to replace the aorta itself? Is the aorta calcified? And if so, is it calcified where? Are you going to have a problem at the STJ or closing the aortotomy? Are you going to have a problem with cannulation or a question about cannulation? Are you going to have to selectively cannulate the aorta somewhere? You can still do the minimally invasive approach, but it's just good to go in armored with that or armed with that information. What is the aortic annulus like? Is it heavily calcified? Is it, you think it's going to be a problem? Are you going to have to enlarge it? All of those things are helpful by the CT. And the other thing has to do with the relation of the aorta to the chest wall and the third, I should have third or fourth interspace up here. Because again, if the aorta is down here through a small mini upper sternotomy incision, then you're going to be in real trouble trying to get to the aortic valve. If it's in its normal location, whether it's tilted like this or tilted like that, it's going to be no problem. But we've all seen patients, you do a full sternotomy and the heart's way down here. That's a problem if you're trying to do a small incision case. So CT and minimally invasive AVR, again, just to quickly review this since we're focusing on the technique, for both mini upper sternotomy and the right intercostal approach, you're going to assess the aorta for calcification, the degree, the location. You're going to look at the annulus, the size, the location related to incision. If you think at all you have a very small annulus and this is your second, third, or fourth case, I would not do this. I would caution you as an early case to not do a bicuspid valve, because the sinuses can be quite deep and it can be difficult and challenging if you're at all uncomfortable through the small incision. You want to get the non-contrast CT like we talked about. You're going to look at the third or fourth intercostal space for the J incision, and you can take the contrast CT And you can look at the actual views, and what I do is you actually roll back and forth. You count the ribs as they come off the spine. So you go 1, 2, 3, 4, third interspace, and by that time you can see the aortic annulus, and it has come to that position. And you can say, okay, I can go into the third intercostal space, or I can go into the fourth intercostal space. Fourth intercostal space is the more commonly one used. The third just means there's going to be less division of the sternum. Again, in the right intercostal approach, the right anterior thoracotomy, you're going to have to do. You want to do a CTA of the chest, abdomen, and pelvis. Why? Retrograde arterial perfusion. And again, same thing. You're going to assess or look at the aortic annulus for position of the intercostal exposure. So, if you have a dilated aorta, if you have ascending aortic calcification, and again, this geometric relationship, they're all very important. Now, pre-op line placement, Dr. Stout has already gone through this, but again, just to review, coronary sinus catheter placement, we think is essential for optimal exposure. You don't want the coronary sinus coming out of the wound. Some surgeons say, put that in. Fine, you can do that if you want to. It's just another thing coming out of the wound. And once your cardiac anesthesiologists are trained to do this, again, it's like putting in a swan. It doesn't really slow the procedure down. As David said, 30 minutes, I say about 20 minutes. If they're having trouble getting in at 20 minutes, it means it's probably not going to go in. So we'll just abandon it and use standard antegrade cardioplegia. But as all of you know, it's difficult sometimes seeing that right coronary artery to cannulate it, and it can be even more difficult in a minimally invasive approach to see that. So that's why I like to have the retrograde coronary catheter in. The patient will be heparinized about 10,000 units for the coronary sinus catheter because the channels under the catheter are small, and so you have to get used to having a little more bleeding going in when you're opening up. All that's done beforehand, and you make your skin incision going through the sternum. It's going to bleed a little bit more. I like to point that out. The non-steerable catheter is used to be a steerable catheter. That's the new catheter that Dr. Stout showed you is what we routinely use now. Very important, I think, to use echo guidance and fluoroscopic confirmation. This is something, again, about the team approach. I don't put the catheters in, but I know a lot about them, and I know what's supposed to be going on. And quite often, if they're having trouble, I'll go in the room and say, what do you think? Because remember, you're going to be depending on that catheter. And so you're going to want to be comfortable, and your cardiac anesthesiologist is going to want to confer with you to say, okay, do you like this position? And you're going to want to know enough about it to say, I think that's okay. I don't think that's far enough in. I think that's too far in. Could cause a rupture when you put up the balloon. All those things are important. So I have, over the years, familiarized myself enough with this to know that I'm happy with the position of that and the placement of the catheter. I think that both of these modalities are important. I came from the East Coast, and I practiced in Norfolk, Virginia, nearly 20 years. And when we started this in 2004, 2005 there, the cardiac anesthesiologist did not use fluoroscopy. And it's sort of an East Coast, West Coast thing. West Coast guys use it, the East Coast guys don't. I don't know how that turned out that way, but that's just the way it is. And upon moving out here, I thought it was an unnecessary step, but as David has pointed out, he's very facile with it. We got it timed just right. It never slows up the case. And once your cardiac anesthesiologist gets used to doing it, it really minimizes and cuts down on the time of the placement of the catheter. And the PA vent, excellent for venting. Again, there have been cases, that you just couldn't get, it would have been very difficult and dangerous actually to try to put the right superior pulmonary vent in from a mini upper sternotomy because you're working straight down, the vent goes like this. You don't really have the advantage of having been able to stretch the sternum open like you do on a sternotomy where you've got more of an angle to get into the right superior pulmonary vein. So that, if you have the pulmonary artery vent in, for many reasons that takes a lot of issues off the table. So exposure. Now I think this is very important. We're going to go over these in detail. So it's a midline upper sternotomy with inverted J into the right third. I would take that word rarely out. I've been doing more fourths recently. The third can be a little bit challenging. So it's third or fourth. I would say across the country it's more commonly fourth. So, and you just do a longitudinal pericardial with inverted T like you normally would for the extent of the incision. So at this point, what you do, before you remove the retractor, actually, you place the pericardials in, okay? And I put in 6 pericardial stitches, 3 on each side. And the key is to put them in and you're going to put them in the skin more cephalad in the pericardium. So if you're doing you put the 6 stitches in, take out the retractor, and then take those stitches, you leave those with the needles on, you leave those, you put those to the side, you take out the retractor, then you take the stitches and you put those in the skin about 1 centimeter above, or cephalad, where you put them in the pericardium. And what's happening there is that the pericardium, like a cradle, is being pulled up, but it's also being pulled cephalad. It's pulling your aorta and ultimately your aortic annulus and your aortic valve up and cephalad. And you'll be amazed sometimes when you first open the pericardium, you go, oh my gosh, I mean, how am I ever going to do this? It's really deep in there. You put that in and you'll be amazed at how much the aorta is pulled up, almost too much sometimes. It's almost sitting like right in the middle of the wound once you put the retractor back in. Okay, that's a very important key step. So we're going to do a standard aortic cannulation, venous drainage. Some people do atrial cannulation. Again, it's in the way, it's in my way. I've never liked it. I've done it once or twice and I abandoned it and went to the groin. We used to cut down on the groin and do a venous cannulation. We now do percutaneous with modified Seldinger technique. We think that's preferred. We have eliminated essentially lymphoceles from that technique. And no stitch in the pulmonary vein. So standard techniques of the operation: transverse aortotomy versus aortic transection. I hardly ever transect the aorta. Sometimes I think with a mini upper sternotomy incision it can be a little bit difficult getting the aorta aligned properly. So if I feel like I need to get complete exposure, I go circumferentially all the way around and leave about 1 centimeter or a few millimeters attached posteriorly, and that keeps the 2 edges oriented. When you're just starting, I think the commissure retraction sutures are important. I don't really use them anymore, but it really helps to sort of pull up the annulus. So there's a couple things. There's a couple things that are important at this stage of the operation. So when you go on the pump, the heart will get decompressed, and there's really nothing else you're going to do other than free up between the aorta and the pulmonary artery and put the cross clamp on, open the aorta, start the operation. So if the aorta feels to be normal, I don't do this, I'm careful doing this in older patients and fragile patients, but if the aorta is of good substance, your CT scan looks okay, it doesn't look dilated, I will place the clamp about 1 centimeter lower than I normally do, sometimes 1.5 centimeters lower than I normally do, and I will pull it up. And then I will sew it to the upper part of the incision up here. That, again, pulls up the annulus. So this is sort of step by step. You're gaining the exposure that you need to have. And you just pull the clamp up. You sew the clamp up to the skin where it's turned over like this. And then you want to make sure the clamp's like this. You want to make, if this is the aorta and the clamp is like this, you want to make sure that the clamp is not like this, because that will impinge upon the posterior annulus. So once you put the clamp on, you pull it up and you sew it up here. You put some towels back here so that it's not doing like this. Does that make sense? That's very important because this is going to bother your exposure. But if you clamp it low, pull it up, sew it up here, fix it, and put the towels back here, then you're going to have all the exposure in the world. And then the commissure retraction sutures, I think, are important when you're first starting. Just put them in the commissures, and so you've done everything there that you need to expose. If you do all of these steps, exposure will, never say never in our business, but will never be a problem. You just won't have a problem with exposure if you do all these things. Any valve. I put in just about every valve through this incision. Mechanical, tissue, it doesn't make any difference. So now let's talk a little bit. So you've done your operation, you're getting ready to de-air. That is really echo driven and guided. You're going to do standard plus a little bit longer. We just really make sure we don't have any further air. What I would say about the pulmonary artery vent is that it does a very good job, and it sometimes does almost too good a job, because remember, you're not collecting from the LV. You're collecting from the pulmonary artery. So it takes a little while for all that to fill up. So I usually turn off my vent at the moment I'm starting to close my aortotomy, so that I don't, and I'd rather have some running out there than having have that concern, because the LV will be, in most cases, completely evacuated. And it takes a little while for that to get over there from the pulmonary vasculature. But we have a cooling needle in place, active root venting the whole time that we're allowing the heart to start beating, all the usual things, turn the patient to the left, shake the table, all that stuff. And we confirm by echo that there's no further air in the ventricle or the left atrium. And that's just a standard aortotomy closure. 2 stars on this one. Place your RV pacing wire before you take the cross clamp off, because in many cases you'll never see the RV again. Once you take that clamp off, first of all, once you cut the stitch, aorta moves down, heart moves down, take the clamp off, heart starts to fill up, moves up against the chest wall. You're never going to see the heart again to put the RV pacing wire on. So be sure to do that before you take the cross clamp off. I have done that once or twice, and it's a miserable experience. So be sure not to do that. So this is what we do it through. This is the incision. It's usually about a 2-inch incision. This is a Blake drain site, and the chest tube site's not really on the screens over here. I used to just put in a Blake drain, and then I had a patient tamponade with just a Blake drain in, so I don't trust them anymore. The chest tube I put in from the right pleural space, traversing the pleural space, and it goes into the anterior mediastinum. We take the chest tube out 24 hours, leave the Blake drain in for 48, 72 hours. And this is the post-op care here. So at this point in time, this data is a little bit dated now. It's about 2 to 3 years old. We had extubated about 70% of our patients in the operating room. I think Dr. Stout alluded to that, or the use with the LMA. We put the chest tube through the right pleural space to the anterior mediastinum, and a Blake drain is brought through the intercostal space. They usually spend the overnight, one night in the ICU, and the Blake drain stays in for 48 to 72 hours. These patients tend to weep a little bit more, and we've actually sent a couple patients home, if necessary, and take the Blake drain out in the office. Discharge 2 to 4 days, and like I said, most patients are back to work usually within 2 to 3, or can go back to work if they want to, full activity within 2 to 3 weeks. We usually have them have the usual sternal precautions that you talk to patients about with full sternotomy. So now let's talk a little bit about how sutureless valves are going to impact the work that we all do, and how this may interact with TAVR and sutureless valves, and where we may be, where we're going to be 2 to 4 years from now. So I really think it's going to change the equation about how we think about our patients. So this is, I'm going to take you through a few slides of the intuitive valve. Are y'all familiar with the intuitive valve? It's a valve that has a platform basically based upon the TAVR concept of a subvalvar frame that is balloon expandable. There are a couple of others, the Percival valve and Elite valve, or the Enable valve that we'll talk about. But once you do the routine removal of the tissues, then you put these 3 guiding sutures in. Those guiding sutures are then placed through places on the Magnetized valve. Do you guys use the Magnetized valve, by the way? The Edwards Magnetized valve? So, there's black marks on there that appeared several years ago, and we didn't know why I said, what are these black marks doing here? I never used them. Well, it was for this intuitive valve. They didn't tell us that, but that's why they started putting them on there years before they came out with it. But so those are the sites that you put the guiding sutures in. You simply lower this deployment device into place, and the balloon is in this shaft here, and the balloon is expanded. This frame, which you see here sort of tilted in all the way around, is now expanded out, and this is the balloon here, and this expands about 1.5 millimeters outside of this. This is now intraannular, not supraannular, and the sewing ring, which has no sutures in it, is now sitting above the annulus. But this portion of it is intraannular. This is the balloon here. This is inside. They basically just cut this in half to show you that this is the balloon on the shaft. So you cut these sutures that are holding it. You take the whole thing out and you tie these down. We now use a core knot for these, and the valve is into place. So this is what I just showed you is the intuitive valve, which is now called the Intuitive Elite. It's a 2nd generation valve. They're working on a 3rd generation valve. It's the Magnetized valve utilizing TAVR principles of fixation, which I've just gone into. The beauty of this is that we know the biologic characteristics of this valve. We know the durability of this valve. The Magnetized valve has probably the most studied valve in the United States because it was put under scrutiny by the FDA in the mid-late 1980s and 90s, and so we've got tremendous data on this valve. It was painful at the time, but now in retrospect, it was the greatest thing that ever happened to the valve. There's a recent publication in March you may or may not have seen yet, published in the Annals of Thoracic Surgery, looking at 12,500 and some patients from the Cleveland Clinic with a duration, if implanted over the age of 65, of about 85% of those patients or valves will still be working well 20 years later. So it really is sort of the gold standard. This valve that is here is the identical valve. It has the same fixation process, it has the same tissue integrity, it has the same biology, and we know how it's going to perform. The Percival S valve is a bovine pericardial valve, and it's on a self-expanding nitinol frame, and it's truly sutureless. You may put in one suture, but basically you put it in and the valve expands to the conformity. One of the downsides of this valve is that it only comes in 3 sizes, and so that's going to be a little bit limiting for the valve, but it actually works very well, and it's been in Europe for a while, and it's coming to the U.S. The 3F enable valve is an equine pericardium on self-expanding nitinol frame, which is truly sutureless. I'm a little bit concerned about this valve, and it's just a personal comment. We know how bovine pericardium works in the bloodstream. We don't know how equine pericardium works in the bloodstream. And I think it's a bit of a leap to assume that it's going to work the same way, bovine and equine pericardium. We'll see. But that's a little bit of a concern I have for this valve. The point about this is that they'll all ease the application of minimal incision surgery, because one of the major issues with minimal incision surgery, especially the right anterior thoracotomy approach, is suture management, suture placement and suture management. Small incision, you got 12, 14, 16 sutures coming out of the wound. That can be a problem. That goes away with these techniques. Dr. Montage at Pinnacle Health in Harrisburg, Pennsylvania, has now done 100. He's our highest implanter in the Transform trial here in the States. He's done 100 implants with 100% success with one patient that has mild to moderate aortic regurgitation, which of course is, would be everybody's concern. And he's doing these now he's done about 10 cases through a 4th intercostal space incision, dissecting up the pec muscle pretty aggressively, but then going through the 4th intercostal space to implant the aortic valve. And the reason for that is that he's not had any problems is because he's very familiar with doing the first 85. Yeah, Brody. The Intuity Elite. Yeah. I can't tell you much because I'm the national co-PI on this, but I can tell you that this will be available probably by the middle part of next year in the United States. Do y'all have it now? Do y'all have the Intuity Elite now? Okay. The Triton Trial, which was the first trial that got the CE mark in Europe, was done about 3 or 4 years ago, and it's commercialized now in Europe, and many centers are using it routinely. But I truly think that as we go forward, we're going to be doing this routinely in the next 2 to 3 years. So this is what the Intuity valve looks like. It's from here up is the identical valve that you use in the operating room. It has this frame, it has this sealing cloth on it, and there's a stainless steel frame that is balloon expandable that I've shown you, that when you blow up the balloon, it goes out to the size, and it's all sized, the balloon and everything is sized to the annulus. This is the first generation. The second generation, Gen 2, which is now called the Intuity Elite, the difference is that one of the problems that we had in the trial is that this cushion, as you advanced it into the annulus, you got a little resistance. Once this started moving into the annulus, from here down was okay because it was turned in. But once you started hitting this, it was a problem getting it in. We think that maybe caused some of the early failures that we saw. So the Gen 2, and so the engineers finally realized that this really wasn't doing anything from here up. This polyester sealing cloth was not doing anything. So that's been eliminated, and this is the only part right here, because once that gets expanded, that's the part that's actually hitting the annulus. This is a Percival S valve, and here's again the nitinol frame, fully expanded. This is bovine pericardium, and this is a 3F enable valve. Looks fairly similar. This is a paper I was just referring to. So 12,569 implants from 1982 to 2011. The structural valve deterioration at 10 and 20 years were 1.9% and 15% overall. In patients over the age of 60, under the age of 60, 5.6 and 46%. So clearly you have a drop-off under the age of 60, but over the age of 60, remember we used to think about it being 65. I'm very comfortable now talking about patients after this has come out between the ages of 60 and 65 that this is going to be a good, the statistical likelihood that this is going to be a good long-term durable valve for them. So, when we think about mini upper sternotomy, we're clearly safe, reliable, predictable. Patients benefit. I didn't get into this a lot with the data I showed you earlier, but there's less transfusion, less ICU hospital stay, less vent time. A CT is clearly necessary for planning. We've gone over that ad infinitum. And then we feel here that to really have a full platform, to have all of these tools in your toolbox, you want to have the coronary sinus catheter, the endovent catheter, the femoral venous cannulation, and venous drainage. So one thing I would say is that if you're starting to think about doing this, there's several ways to think about getting started in this. The first thing to do, the next aortic valve replacement that you do your sternotomy, do everything like you're supposed to, get the aortotomy open, but before you start cutting out anything, either take a piece of cardboard and cut it out so that it's about that big and lay it over top the incision, or just take some towels and drape them like this and say, okay, I'm going to stay in this confined area, and I'm going to work in this confined area until you're no longer comfortable, and just rip them off and go do what you need to do. But you get comfortable doing this procedure in a very staged, progressive manner. The second thing I would say is that I think it's essential to have single-shafted instruments to do these procedures, because you're going to get yourself in positions, with this incision like this, that you're not going to be able to do this with the scissor-type instruments that we use. The instruments that we use basically were created back in the Civil War here in the United States. I mean, they're just, they're ancient, but we still use them in 2015. But single-shafted instruments allows you to have a lot more flexibility with what you're doing. The third thing I would say is that Dr. Stout referred to earlier in terms of beginning to do these things is that you want to make sure that your cardiac anesthesiologist is comfortable doing the coronary sinus catheter and the pulmonary artery vent. And the way to do that is to have them just go do that in the morning. So when we first started here, David had tremendous experience from a heart port experience, but he hadn't done them for a few years. I said, look, just go do that. Go do two of those things. We're going to be doing an AVR CABG here, open case. You can do that. I'm going to do rounds, have a cup of coffee. Call me when you're ready. And obviously you want to pick a patient that doesn't have a 99% left main and might get a little hypertensive and then have a problem. It's, the appropriately selected patients are going to be fine under anesthesia for half hour, 45 minutes. Let them do that for a few things, because what you don't want to do with your first, second, or third case is try to do all this stuff at the same time. So what you're doing is you're attacking each one of these things as a template, as a box. So, okay, I'm comfortable now with single-shafted instruments, or I'm comfortable working through an artificial small incision, or my anesthesiologist is comfortable doing these things. And then you put it all together on a properly selected, nice tricuspid aortic valve stenosis that the aorta is fine, the guy or gal is 72 years old, everything looks good, and normal body habitus, and then you begin to sort of build your program on that. Okay? So what I'm going to show you here, what's on the left is this is the echo. We're going to be looking at the guide wire. This is the guide wire going up into the femoral vein. And again, you just clean off the anterior surface of the femoral vein. And if you're not familiar with guide wire skills, that type of thing from the TAVR experience, probably would be good to do these open through a very small incision, but all you have to, if you do it in an open way, then you just clean off the anterior surface of the femoral vein. That way you don't go around the femoral vein. That way you'll minimize the risk of a lymphocyte developing there. We usually put 2 concentric purse strings of 5-oproline in that area, and let's see. So you're seeing here that I moved too quickly, but the guide wire was up into the SVC, and I'm measuring the cannula on top of the patient to know exactly where it's going in. So now we've done the sternotomy, we're open, we're cannulated up here, and the purpose of this, I want to show you that after you get to this point, it's just like you're doing a normal aortic valve replacement. Cross clamps going on here. I didn't really demonstrate in this one, I do in the new film, but where you pull the clamp up and sew it in. This is Dr. Stout's coronary sinus catheter, and we demonstrate echocardiographically that we're giving, the plege is getting there. I'm putting in the retraction sutures here, standard aortotomy. And this is what you're seeing as a surgeon. I mean, it's very straightforward, and it's really simple to do. So we're cutting out the valve. This is a little discolored from the other one because we went back and forth from a head cam to an overhead cam. Obviously heavily calcified valve, but we do not alter any techniques from this to a standard full sternotomy. We're going to be sizing here, and putting in the sutures in the usual fashion. A little advertisement there for you, and then and the valve going in. And so again, this is exactly how I do a standard full sternotomy aortic valve. Now in this case, this is again before we started using a core knot about 1.5 years ago. We are hand tying the knots, but we use core knot routinely now for all of our aortic valve replacements. One of the things that concerned me initially about the core knot was that whether the tissue, the valve would ride up against the core knot and abut that abrased the tissue. So I had them take one of the 3 of the core knots. We sent them down to the lab, down to Edwards, and they tried to put it as close as they could. And on opening and closing in the test tank, there was no abrasion. However, if you do the core knots, you need to make sure that what we do here is we take that suture deep on the undersurface and then out on the outer edge of the valve sewing ring, so that when that core knot comes down, if this is the plane, this is the valve sitting here, the core knot sits like this rather than like that. You do that everywhere except the left main, because the left main, it can sort of tilt in there. So you want to be cautious. Just a couple of tricks there for that. Check and make sure everybody is pulled up like they're supposed to be down there. Everything looks good. Closing the aortotomy, de-airing. Again, all these are very standard things. You can see that appendage now, how that would be in your way if that hadn't been out of the way and completely drained. Putting on the pacing wire before we take the cross clamp off. In this case, it was pretty easily to see. And then Dr. Stout doing an echo, make sure that we have no PV leaks and the valve's working okay. I'll turn on a little color here in just a minute. You see, open the color bar and there's nothing down here below. Looks quite good. And again, all very standard technique. That's the incision there. This guy was extubated within an hour, ambulated first post-op morning, third post-op today. He was back to full. This guy was a cycler. There's a lot of people ride bicycles in this part of the country, and so he was back on his bicycle, sort of against my judgment because I was worried about him having an accident hitting the stem on the bike, but he went out and he was back to full activity in about 2 to 3 weeks. So.